Okay. I think we don't need to record this practice session.
I can see them.
And you see the first slide?
Yes, via that guideline.
Okay. So my job over the next 10 minutes is to talk about why adapt guideline. And for the agenda, these are the things I'll be trying to cover. I'll briefly talk about what are health guidelines to set the scene. I'll then talk about benefits of health guidelines, typical steps involved in developing health guidelines, and then the rationale for adapting guidelines and benefits of adapting guidelines compared to developing guidelines de novo. I have no conflicts of interest to declare. In my view, health guidelines can be broadly classified into these three categories: clinical practice guidelines, public health policy guidelines, and for the lack of better word, broad health guidelines. Excuse me for the typo there. So the Institute of Medicine has given a definition of a clinical practice guideline. It is the most commonly used and cited definition, and it defines clinical practice guidelines as statements that include recommendations intended to optimize patient care that are informed by a systematic review of evidence and an assessment of benefits and harms of alternative care options. So you can see at the heart of the guidelines are recommendations based on systematic review of evidence and assessment of benefits and harms of alternative care options. I have not come across any standard or good definitions of public health policy guidelines or broad guidelines. But as you know, WHO has the tradition of developing and disseminating guidelines, and they have been doing that for decades. And if you look at how WHO defines their own guidelines, we'll be able to make out what health policy guidelines and broad health guidelines are. So here is how WHO defines its own guidelines. A WHO guideline is defined broadly as any information product developed by WHO that contains recommendations for clinical practice or public health policy. And further, they explain recommendations are statements designed to help end users make informed decisions on whether, when, and how to undertake specific actions, such as clinical interventions, diagnostic tests, or public health measures, with the aim to achieve the best possible individual or collective health outcomes. An example of clinical practice guideline: this is a WHO guideline for the pharmacological management of hypertension in adults, published in 2011, if I remember it correctly. It contains recommendations on initiation of pharmacological treatment for the management of hypertension in adults. It provides recommendations on target blood pressure, the follow frequency, and other things. And the primary target audience for these guidelines, for this guideline, are clinicians and allied healthcare providers. An example of public health policy guideline, a recent WHO guideline on air quality. It contains recommendations on air quality guideline levels in relation to health outcomes for particulate matter and other harmful gases. It provides recommendations and targets to guide reduction efforts towards achievement of air quality guideline levels, and also recommendations on good practices for the management of particulate matter. And the target audience for these guidelines are policymakers, technical experts, program managers, and other stakeholders. And finally, here is an example of a broad health guideline, a guideline on abortion care. It has recommendations on integrating aspects of care across all domains needed to provide quality abortion care, laws and policies, clinical services, and service delivery. And in this case, the target audience are policymakers, program managers, healthcare workers. And this guideline has a chapter on clinical care, including management, pharmacological management of abortion. So in a nutshell, a clinical practice guideline is intended for clinical care of patients, and and the target audience are clinicians and healthcare workers, whereas a policy guideline is focused on public health measures for prevention and mitigation and control of health conditions or risk factors. And the target audience are policymakers and program managers and other stakeholders. Briefly about benefits of health guidelines. We all know that health literature could be very voluminous, and that is the case for most health topics. And it comes in different forms and shapes, and it is very difficult to keep up to date on all the recent developments. So guidelines provide one-stop resource on a health topic. They facilitate evidence-informed clinical practice and policy decision-making based on best available and up-to-date evidence. And they facilitate planning and effective targeting of resources, and this is very critical in low and middle income countries, and they help target resources on areas that offer most health improvement. They facilitate team-based care in which individual team members can be identified and to play the major role, and their roles can be defined and how they can work as a team towards targets that are necessary for optimal outcomes. And there is strong evidence suggesting that implementing guidelines improve process of care, and they also improve clinical outcomes. So these are broadly the approaches to developing clinical guidelines. So you can develop guidelines from the scratch, new guidelines called as de novo development. You can adopt guidelines that are developed for other settings by other cultural, in other cultures or in other health systems can be adopted to other health systems. I mean, not really an approach to development because it simply means accepting as a whole, just copying and pasting it to a different setting. Adapting guidelines wherein you accept a guideline from another setting or other system and you customize it to your target setting. And then finally, hybrid approach, which I think is the most common one, wherein some of the recommendations of the guidelines are developed de novo, some are adopted, and some could be adapted. So these are the key steps. I mean, I will mention some of the key steps that are involved in developing guidelines de novo. The first step involves planning, and these are steps from the WHO handbook. The Institute of Medicine and other such organizations also report similar steps. So the first step is planning, and as illustrated in the figure on the right side, these are the things that the guideline development group needs to plan at the beginning. Setting up the guidelines group, it includes setting up the steering committee, the group for evidence synthesis, group for writing, group for external review, declaration and management of interest. This is very important to render transparency to the guidelines and to minimize bias in developing recommendations. Formulating the questions, and these could be questions related to screening, diagnosis, management, prevention, mitigation. Retrieving relevant evidence and synthesizing the evidence, including conducting meta-analysis if needed and if feasible. Assessing the evidence, the quality of the evidence, and then developing the recommendations based on the evidence and grading those recommendations based on the quality of evidence that informs those recommendations, getting it reviewed externally, and then finally producing and publishing guidelines. So, I mean, a lot has been said about adapting guidelines in the recent past. You will find a lot of literature on it. So the adaptive collaboration defines guideline adaptation as systematic approach to considering use and or modification of a guideline produced in one cultural and organizational setting for application in a different context. So coming to the crux of my talk, why adapt guidelines? As you have seen, developing a guideline de novo involves several steps. It is a resource-intense process. It needs significant time and funding. It needs people with diverse skills. To name a few, it needs subject experts, it needs methodologists, it needs economists, it needs writers, it needs editors. And often there are strong organizations who are involved in developing guidelines. If you see examples, successful examples from high-income countries, you will find that there are very reputed and strong organizations involved in developing guidelines, which are commissioned, tasked, and funded by governments or NGOs to produce guidelines. And these are generally called task force or guideline developing groups. Some examples are the American associations, various associations, European associations, the World Health Organization. And there is increasing demand to produce guidelines more quickly as more and more evidence accrues. And de novo guideline development being a lengthy process, catering to the demands of developing guidelines quickly, implementing them, and updating them is often challenging. The state of affairs of guidelines in low and middle income countries. So Somadeep and the team assessed the quality of clinical practice guidelines in India a while ago. And they used the AGREE tool to assess the quality of guidelines. And the main finding was most of the guidelines were of suboptimal quality. On the y-axis, you see the mean scores for each of the domains assessed: scope and purpose, stakeholder involvement, rigor of development, clarity of presentation, applicability, editorial independence, and overall score. And you can see that the domains that scored the least were rigor of development and editorial independence. Another recent example, appraisal of quality of clinical guidelines in obstetrics and gynecology, again from India. Similar findings, very low scores for rigor of development and editorial independence, and also in this case, applicability. So, this suggests that either there is lack of resources or skills, or there is lack of information sharing, or there is lack of understanding of standards, understanding and following of standards for developing quality guidelines. Other reasons for adapting guidelines include it simply saves resources. So when there are high quality guidelines available, why to duplicate them? And this is very important for limit settings, which often have limited resources. You can make guidelines available early to inform policy and practice. And often when you are working in geographic regions like Africa or Europe or South Asia, the evidence is not going to be very dissimilar. So if you are developing, say, guideline for an African country, you would consider evidence from all the other African countries relevant. So often the evidence is similar, if not same. So one can avoid the duplication of reviewing the same evidence and producing the same recommendation. So we can ponder, why not just adopt guidelines, high quality guidelines? Why to bother about adapting them? Although the evidence base could be same in a lot of cases, yet there will be cultural and health system variation between settings. Applicability to local context particularly will be a challenge when you don't have enough resources and skills to implement guidelines from other settings. Legal and regulatory requirements vary from jurisdictions to jurisdictions, and that needs to be taken into account. And when you don't have people from the target settings involved in developing guidelines, there's that lack of ownership that could be a challenge for implementing guidelines. There are good examples from other countries that have successfully established the processes of setting up guideline adaptation processes. And one such example is from New Zealand. So until 2012, the New Zealand Guidelines Group, an independent not-for-profit organization, was developing guidelines since 1999. In 2012, the group went into liquidation, so it was dissolved. Subsequently, the government of New Zealand provided funding to the Best Practice Advocacy Centre, which got into agreement with the NICE in the UK. As you all know, NICE is a very reputed institution, and they have been producing guidelines for a very long time. So NICE signed an agreement with BPAC to allow their guidelines to be adapted and reproduced for use in New Zealand. And this website, if you visit, it has a lot of guidance on adapting guidelines and disseminating them. So I'll stop there and thank you for your attention. I mean, if there is time, I can take a few questions. If there's no time, we can do a Q&A session at the end.
Thank you, Dr. Salam. I think we can do a Q&A session at the end of the talk. I request all the attendees to please put their questions in the Q&A box. Your talk was very insightful, and I must say it answered one question I've carried since last year, COVID times. Why did we just not adopt guidelines? You know, the CDC had a guideline. There were international, national, state, local guidelines. And why could we just not adopt or have a single, guideline from one international organization? So it was a very good overview of the guideline development process. And I think it links well to our next talk by Dr. Yang Song, the lead speaker for today's event. So Dr. Song is a medical doctor herself, specializing in obstetrics and gynecology. She is also doing her PhD, and her research focuses on the methods of clinical guideline development and adaptation. She has extensive experience in guideline adaptation internationally, and she has led the development of the Right Adapt checklist. So Dr. Song will be talking to us about the checklist and the challenges people might face when they are adapting guidelines. So Dr. Song, please, if you may take over.
Thanks for the introduction and organization. And I will be talking about the research we have done for the guideline adaptation area, but also thanks to Dr. Salam, give a very nice overview of the clinical guidelines. So I could start right away in adaptation, I guess. Let me share my screen. And in present view, can you see the slides?
Yes. Yeah.
And not sure whether we are come from different time zone, but good afternoon, good morning, and good evening to everyone. I'm Yang Song, and today I'm glad to share the research work regarding adaptation. I will present the work have been done in below sequence. First, a brief background of guideline adaptation, then two studies we conducted for this area, the current practice of guideline adaptation based on semi-structured interviews, and a reporting checklist developed for adapted guidelines. In the end, we could have a small discussion on future research and steps. So guideline adaptation means the use of existing trustworthy guidelines without modifications or including de novo additional recommendations to provide local, regional, or national guidance. It is a systematic approach for implementing the guideline developed in one setting to another, or as an alternative approach for guideline de novo development. So by following a systematic approach, adaptation working group could get benefit from the quality and validity of source guidelines, saving time and resources while developing contextualized recommendations. And currently, there are more than 8 adaptation frameworks available, previous research has classified them into informal and formal methods. Informal adaptation methods mean those adaptation processes without a systematic or rigorous framework. For example, doctors from primary care or rural hospitals may modify the recommendations based on their setting without following a systematic approach. While formal adaptation methods are those established adaptation frameworks as listed according to the timeline. As we could see here, since 2005, the adaptation framework has taken shape and gradually evolved along with the timeline. And in 2011, the adaptive instrument was developed by the adaptive consortium to assess and adapt the existing guidelines. In 2014, the adaptation process was integrated with GREAT approach, named Snap-it through the platform Magic. And in 2017, the adaptation process was starting integrated with the GREAT evidence to decision framework. This framework named GREAT development. If we go inside to look at the development process for each framework, it's not hard to find that the adaptive instrument is the comprehensive framework for adaptation. In addition, there is a clear evolution trend from the traditional adaptation frameworks toward the combination of the GREAT approach. And it's not surprising as the process of adaptation highly relies on the source guideline development process, and the GREAT approach has been widely used for guideline development in the last decades. Here is a summary of the adaptive process, which has developed based on literature review and collaboration with other adaptation research team. The adaptive process includes 24 steps grouped into 3 stages or phases with 9 modules. In the setup phase, adaptation working group may establish guideline committee, make a plan for adaptation, and check if adaptation is feasible, including the required resources and skills available. In adaptation phase, adaptation working group may define a health question, search and screen source guidelines, assess the guideline quality, content, currency, whether it's up to date, and the applicability to their citing. Then review and select which recommendations to adapt. Finally, make a draft for the adapted guideline. In the finalization phase, the adaptation working group may conduct an external review process, make a plan for future updating, and finalize the adapted guideline. Then the most recent framework for adaptation is GREAT development, as we see in previous timeline. This framework was developed based on GREAT evidence to decision framework. It mainly contains several sections, including the selection of guideline scope and key questions, the assessment of the source materials, including the currency of the recommendation, quality of the guideline, etc. Then go through the process, decision-making process on whether to adopt, or develop the novel recommendations. So by following this framework, adaptation could be achieved by completing or updating the ETD framework from source guidelines. That's 2 different approaches. However, the comparison among the frameworks or the previous identified adaptation frameworks showed some similarity in the initial and final phase, including the planning stage, external review, and updating plan. And there are also several notable differences among the framework specific in the adaptation phase regarding the structure of the committee, adaptation methods used, and the formulation of the adapted recommendations. although there are many frameworks are available, published adapted guidelines are generally of low quality. One systematic survey on the quality of adapted guidelines using a grade 2 instrument got a mean 57% for rigor of development domain. And in addition, the reporting of the adaptation process is poor and not based on a published framework. In addition, new methodology papers are still emerging, and the current practice of adaptation is still unclear. As we might know that reporting guidance enhance the accurate, complete, and transparent reporting of the health research. There are different reporting checklists for the novel guideline, including the right statement. But the checklist for the novel guideline development does not cover specific steps for guideline adaptation. For example, the steps for adaptation process. So based on the background, we launched an international working group to develop a reporting tool for adapted guidelines named the Right Adapt. And here is an overview of the stage. The development process has multiple stages, including the semi-structured interviews to explore the current practice and challenges of adaptation. On one hand, to better understand the current practice. On the other hand, to optimize the content of the checklist and enhance its validity. The first study explored the current practice and challenges of guideline adaptation. And it is a qualitative study based on semi-structured interviews with adaptation experts internationally. Participants were identified from published adapted guidelines, recommendations from Right Adapt working group members, and GENE conference attendees list. We collected the characteristic of participants, their current practice of the adaptation process, and their views and experiences about challenges. And we conduct a framework analysis on the guideline adaptation methodology in combination with their experiences, and a semantic analysis on the specific challenges with their experience. And finally, we conducted 10 semi-structured interviews from December 2019 to January 2020. Participants were from 9 different organizations of 7 countries. We summarize the reason for them to adapt guidelines. The most common one is to adapt existing guidelines for their de novo guideline development process. They retrieved and adapt existing guidelines that could potentially answer their questions, saving resources and time while avoiding duplication of efforts. Some organizations also focused on implementing source guidelines in their setting through the adaptation process. 3 organizations also updated their own guidelines by adapting newly published other guidelines. And the last organization conducted adaptation process only when there were discrepancies among different recommendations for a same topic. From the interview, we also identified 9 adaptation methods. 2 are overlapped with what has been described in previous research, and most of them are published after the search date of previous research. There are 7 newly emerged adaptation frameworks. 4 of them are organizational standards from high-income countries developed by the organizational expert committees. 1 organization used an approach to appraisal to inform the adaptation process, and the other 2 were adaptation frameworks developed by high-income countries and piloted in middle-income countries through real-life adaptation process. Based on the framework analysis, we kind of summarized the four core steps for adaptation process, including the selection of the scope and source guidelines in parallel, the assessment of source materials at different levels, a decision-making process, and external review with follow-up activities. It's a preliminary research on the guideline adaptation process, but the identified main steps could, with the assessment levels, could help adaptation group to streamline their future processes. We also integrated the main steps and the level of assessment into the Right Adapt checklist. Based on thematic analysis, we identified the challenges faced by participants and summarize them into 5 themes, including limitation from source guidelines regarding the poor reporting and low quality, limited advanced skills of the target setting on the guideline development and adaptation process, resource and time intensity required for adaptation process, and specific steps within the adaptation process and implementation barriers. We also explored how participants addressed specific questions, including the contextualization issue, inconsistency issue, how to update source evidence, and consider implementation barriers. Again, it's a preliminary study, but in summary, from the experience of participants, the panel discussion is kind of a general method to used to address the context differences, inconsistency, and implementation barriers. We also use the proposed assessment level to streamline their solutions. Again, these solutions are only experiences, so more research is needed to establish the international standard for adaptation. So I'm not going to go in detail about this. And the second study developed a reporting tool for adapted guidelines as an extension of the Right Statement. We published the protocol with detailed methods used in a peer-reviewed journal, and the final checklist was published in Annals of Internal Medicine recently. Here is an overview of the development process. First, we established the working group, including 38 participants from 20 countries. I'm glad Dr. Baumick is a co-member of our development process. Then we generated the initial checklist based on the literature of adaptation and experience of the working group member. Then the main part is to optimize the initial checklist. We conducted initial assessment of published adapted guidelines to enhance the validity, semi-structured interviews to explore the current practice, 2 rounds of depth consensus survey to reach a consensus on each item included, external review process with guideline developers and users to improve the usability, and a final assessment with another group of published adapted guidelines to improve the validity. So after each step, we integrate the results and updated the checklist into different versions. And finally, the co-working group critically reviewed the checklist and improved the checklist into version 7 for final approval, and the whole working group has approved the final version. The Right Adapt checklist contains 7 sections covering 27 topics and 34 items. We also developed a user guide to provide user instruction with what to do, an explanation of what to do and why it is important, and real-life examples for each item. The Right Adapt checklist is intended to get the reporting of the adapted guidelines, including the adaptation process and adapted recommendations. Here is an overview of the checklist section by section. In the basic information, we included the topic of title, subtitle, cover, first page, executive summary or abstract, abbreviations, and contact information. In the second section, scope includes topic related to source guidelines, brief description of the health problem, aims and specific objectives, target population and user and settings. The checklist also promotes the reporting of the differences compared to the source guideline to enhance the transparency. The rigor of development section covers all the critical steps within the adaptation process, including guideline adaptation group, adaptation framework or methods used, the selection of the source guidelines, the prioritization of the key questions, the assessment of the source recommendations and how they integrate or synthesize the evidence, and how they assess the certainty of evidence and strength of recommendations and decision-making process. The recommendation section suggests indicating whether the recommendations were developed or adopted or developed de novo, and also providing the rationale for formulating the recommendations, including the differences from source guidelines. Following section covers the external review and quality assurance, funding declaration and management of interests, other information for implementation strategies, updating plan, and limitations, suggestions for future research. If we enlarge one section for us to see as an example, recommendation section is a good one. So item 24 suggests distinguish the recommendations were adopted, whether the recommendation were adapted, adopted, or developed de novo. Item 25 covers the direction and strength of recommendations with supporting evidence. Item 26 is for the important subgroup recommendations, and item 27 suggests the reporting for recommendation formulation or the rationale for the modification. Here is an example of the user guide. As you could see below each item, we provide an explanation including what to do, why it is important, with several examples extracted from the real published adapted guidelines. Well, in summary, the Red Adapt checklist has been developed to improve the reporting of adapted guidelines, focusing on the standardization, rigor, and transparency of the process, and ensuring clarify and explicitness of adapted recommendations. Compared with the Red statement, the Red Adapt retains its merits while sufficiently contextualize the adaptation content. We also include a new section for adaptation process named the rigor of development and 7 new adaptation topics. The Red Adapt could be used by different audience, for guideline developers to inform reporting, for journal editors to ensure the completeness and transparency of the adapted guidelines to be published, for guideline users to assess the completeness of reporting, and for policymakers to evaluate the feasibility of adapted recommendations for local implementation based on the reporting. And future research will be focusing on assessing the reporting of adapted guidelines, evaluating the checklist impact on the quality or efficiency of adapted guidelines, translating the checklist into other languages, standardizing the reporting in the journal. We also will gather feedback for future updating. And yeah, that's all from me. Thanks for your attention and happy to take any questions.
Thank you, Dr. Song. It was a very comprehensive overview of the guideline adaptation process. And also thank you for introducing us to guideline adaptation methods that you specified in your talk. So we'll now take questions from the audience. I'd like to invite Dr. Soumyati Bhaumik, co-head of the Meta Research and Evidence Synthesis Unit at the George Institute, for a fireside chat. Dr. Bhaumik is an international public health specialist working on evidence synthesis, meta-research, health policy, and injury. And his work has informed multiple WHO guidelines, technical documents, and national policies. So I request everyone to please put their questions in the Q&A box. And till the questions start coming, I have one question for both of you. So what could be the barriers to using this checklist? Because there are so many checklists everywhere, and it looks like a very comprehensive one. But like, why do you see anything right away that that might stop people from using it?
Thanks for the question. Yes, we do have a concern about the length of the checklist because we have a comprehensive one and covers all the steps. So the potential solution is that we kind of planning to develop a short version with the key steps to inform the specific steps of adaptation and to improve the usability of the checklist. So that's one thing I foresee now. And yeah.
Yeah, I think that's a very interesting question than something I think we had been discussing when the guideline the right adapt checklist was being discussed, developed too. But I think one of the key problems with guideline adaptation will be very similar to what we have for development of the novel guidelines, which is many people who are developing guidelines are doing it on an ad hoc basis and not like really thinking through about the amount of resources and the technical skills and the methodological power people have. I mean, this is more true for some countries than others because some countries really do it really well. But I know, like, I think like for countries like India, what really needs is a cultural shift where there is more thought on the governance and the investments and in terms of, and not just in money, in terms of the skills and the time and the planning required to develop a guideline. So I think once that is something we achieve that, we can probably be in a very good state to use these guidelines. And I think one of the powers I see of the right adapt checklist, and I think which Dr. Song as well as Dr. Salam mentioned, is like the realities of many low and middle income countries is quite different. And as a result of which, we really should think about adaptation of guidelines as a important key step towards it.
Yeah.
Okay. So I think please, if you have any questions for Dr. Salam, Dr. Song, or in general about the topic, please do that. In the meantime, I will actually ask Dr. Song another question. I think you talked about the implications of future research on this topic of domain, this domain. Would you like to add on how do you see these things being different in high-income country versus low and middle-income countries in terms of research priorities in this domain, if at all, or is it would be the same?
Yeah, thanks for the question. Actually, I think there might be quite a difference between low and middle income country with high income countries, because from the slides and the literature review of adaptation methods, we kind of find that most of the framework were developed by high income countries. So it's kind of a challenge for us because I'm from China. It's the similar situation, I guess, with India, and we kind of lacking of the advanced skills for guideline development as well as adaptation. So that's a big challenge. And for future research to try to solve this, I think we need to admit that the adaptation requires advanced skills, because if we want to adapt the guidelines from high-income countries, or it's a good quality guidelines, they might, or I'm sure they used a very comprehensive methods like the GRADE approach. And for us to adapt their guidelines, we need to understand the skills, the methodology they used. So And then we have to have the adaptation skills. It's a 1+1 more complex process. So first we need to admit this fact. Then I think future research need to think how to streamline, to simplify the process, or pick the key steps that related to the quality for us to use. So that's my so far the thoughts. Thanks.
Yeah, no, so I think that's a very interesting answer, and maybe I will put you a bit on a spot on this with this next question, which is, do you think, and of course we can't see the future, but in your opinion, do you think that a guideline adaptation might be technically and methodologically more challenging than de novo development of guidelines if you really want to do a proper job? Or would the skills be same or less? What do you think?
Yeah, I don't know how to see this, because it's so on one hand it's a very complexity process. On the other hand, we could not force people to use that. I mean, to make sure that the adaptation is all very quality rigor and use high technology for this. So, but I hope with the checklist, reporting checklist, we could make this process transparent, and we could see how many challenges are left for us to solve, and what are new things or aspects emerging for us to improve this quality of the adapted guidelines. Thanks.
Thank you. So there are some audience questions, so I will actually take them up. What do you think about the role of patients in the guideline adaptation process in comparison to de novo process guideline development?
Yeah, is there any rule for it? Yes, actually, as suggested by the great evidence to decision framework, there is one aspect named patient's value and preferences. I think that part can cover the patient's involvement during the development process. And that's for development. And another part is for the implementation. So the guideline users' perspective or knowledge skills to use the guideline is also an important aspect to take into consider when implement the guideline. And regarding the differentiation or differences between guideline and adapted guideline, I think we need to treat those processes the same, because the final product is a guideline for people to use. So both the processes need to integrate the patient's value and the implementation barriers. Thanks.
Yeah, thank you. I think that's really good. I mean, patients are at the core of what we want to do, and they definitely have a role in it. But at the same time, it's quite challenging, and especially to engage patients who are actually contributing to the process and understanding to it. So there is also a need for us to take the extra mile and try to engage patients. Like we have been doing one, and it has been quite a learning curve for us about how to engage patients itself. So I will take another question actually that has come up in the chat from Joseph, which is, do you think the right adapt checklist is good for clinical as well as public health guideline adaptation?
Sorry, could you repeat?
Yeah. Do you think the right adapt checklist is good for both clinical practice guidelines as well as public health guidelines?
Yeah. That's a good question, because at the beginning, we need to differentiate the clinical guideline, the difference between clinical guidelines and public health guidelines. Actually, for at the beginning of the development of the checklist, we kind of decide that the checklist or the adaptation process is similar between different types of guidelines. So it could cover all the not all, but clinically and public health guidelines together. And also during the process, adaptation process, we need to consider many factors regarding the policy or implementation. So this checklist could be used for both guideline development reporting. That's my answer. Thanks.
Thank you. I think that's really interesting to know, and maybe we will explore this as things go and people use it up more. So, and I would request everyone to keep on using the right adapt checklist whenever you are adapting guidelines and talk about it. I know a lot of people do adapt guidelines, so that's good to have at least a checklist, reporting checklist, so that we know what has been done and what has not been done in the process. And taking up another question, so when do you think this right adapt checklist should be used, at the beginning or during or at the end of the guideline development process?
Yeah, thanks. I could repeat can I repeat the question?
Yeah, sorry.
Yeah.
So when do you think the right adapt checklist should be used, at the beginning or during or at the end of the guideline development process?
Yeah, thanks for the question. Actually, I kind of using the right adapt checklist right now. I find it's really informative at the beginning of the development process, because in for example, the rigor of development process, we know which steps we need to report, and we need to keep an eye on to ensure the rigor of the adaptation process. So at the beginning, it's informative, and at the end, for sure, it could be used to report the adapted guideline has been finished. And so during the middle, I think it's also useful because there is a comprehensive user guide, provide the information, how you could report and why it is important. So by reading the guidance, the explanation of each item, I think users might find useful information for the adaptation process during the development process. So I think so. Hopefully the implementation process of this checklist will go in well. Let's see. Thanks.
Mm-hmm. Yeah, thank you, Dr. Bube, for that question which you asked. And I think I completely agree with Dr. Song. I like when I started off my career, I found reporting checklists very, very useful, because it put me in a framework of what I want to write and what I don't want to write, because we're always confused about the structure. And so that's true for all reporting checklists, I think. And it's better to start thinking about it from the beginning and keep on looking at it throughout the process, okay, at each step, and see if I'm following the reporting checklist. It makes writing a lot easier for everyone if you are following a standard structure at least. And I think that's where the power of any reporting checklist lies. And that's what Dr. Song has done in her doctoral work, a brilliant piece of work looking at what are the challenges of guidelines, then trying to understand what are the practices, and then finally coming up with a solution to this in some way. And we'll see its implementation and everything, which I think Dr. Song would further take up as things go on. So really looking forward to see how further work progresses. And just last, if anybody has any last burning questions, we'll take that. Looks like not. So I think I will just end by thanking Dr. Song for attending this webinar from our very, very busy schedule. So thank you very much. It's really a pleasure to have you talk about it. Have an expert like you talking about it and sharing your experiences and research. So thank you very much for that.
Oh, thank you for this opportunity to share the research have been done. And if anyone has further questions, you can just email me or email Pablo, my supervisor. I'm glad to communicate further. Thanks for the organization and invitation.
Thank you.
Thank you to all the panelists and all the attendees for attending the seminar. And I think we can call a close to the event. Thank you, everyone.